where the pacemaker cells like to hang out, okay? They need to reach this threshold line that you can see here before they're able to fire an action potential. And the action potential is what creates the wave of electrical activity through the heart, generating a heartbeat. So they hang out down at negative 60 millivolts, and as sodium ions slowly move into the cell, they become less negatively charged, right? So sodium is a positively charged ion. As sodium moves into the cell becomes less negatively charged because there's positive ions moving into the cell. Once it reaches negative 40 millivolts, you reach threshold. And it's at this threshold that now the cell is able to fire an action potential, where it suddenly becomes much more positive, and then it has a rapid decrease. So what happens as it reaches up to 20 millivolts, positive 20 millivolts, is you have a rapid influx of calcium ions, causing this rapid depolarization. And then in order for the cell to go back to normal where it wants to be, you're going to have an outflux of potassium, and that's the repolarization. Once you hit threshold, you then have a refractory period where the cell is unable to fire a new action potential until it can get back up to threshold. So, just to read the slide itself, pacemaker cells must reach a threshold of depolarization before an action potential is fired. The resting membrane potential of the cell is negative 60 millivolts, and the threshold membrane potential is negative 40 millivolts. The cells then repolarize and have a refractory period before they can fire another action potential. Next, we will look at the ECG. So ECG and EKG are the same thing, electrocardiogram. When spelled with a K, it's because that's the German spelling of electrocardiogram. But they are the exact same test. So ECG, EKG, interchangeable. So when looking at the EKG, we have a P wave. The P wave shown here, that is atrial depolarization. Atrial repolarization is hidden behind the QRS complex, that large spiky looking wave. We then have the PR interval. The PR interval is the distance from the beginning of the P wave to the beginning of the R wave. And in that PR interval is a PR segment. The PR segment is where the electrical impulse slows down at the AV node in order to allow for ventricular filling. So it's a delay in the AV node prior to ventricular contraction or ventricular depolarization. And the reason we have that is to allow for ventricular filling. You then have the QRS complex, which is ventricular depolarization. That's when the ventricles are going to contract. And then you have the T wave, which is ventricular repolarization. And we will watch this lovely video.
Amazon offers hourly employees health care on day one for the whole family.
Where's Jeff?
The electrocardiogram, or ECG, or EKG, is a measurement of tiny potential differences on the surface of the body that reflect the electrical activity of the heart. These potential differences, or voltages, are measurable on the body surface because of the timing and sequence of depolarization and repolarization of the heart. Recall that the entire myocardium is not depolarized at once. The atria depolarize first, and then the ventricles depolarize next. As a result of the sequence and timing of the spread of depolarization and repolarization in the myocardium, potential differences are established between different portions of the heart, which can be detected by electrodes placed on the body surface. The P wave represents depolarization of the atria. The duration of the P wave correlates with conduction time through the atria. For example, if conduction velocity through the atria decreases, the P wave will spread out. Atrial repolarization is not seen on a normal EKG because it is buried under the QRS complex. The PR interval is the time from initial depolarization of the atria to initial depolarization of the ventricles. And so the PR interval includes the P wave and the PR segment, which is this isoelectric flat portion of the ECG which corresponds to AV nodal conduction. Because the PR interval includes the PR segment, it also correlates with electrical conduction time through the AV node. Normally, the PR interval is less than 200 milliseconds, which is the cumulative time from first depolarization of the atria to first depolarization of the ventricles. Increases in conduction velocity through the AV node decrease the PR interval. Take, for example, increases in sympathetic tone. On the other hand, decreases in conduction velocity through the AV node will increase the PR interval. Another example would be increasing the parasympathetic tone. The QRS complex consists of three waves, Q, R, and S. Collectively, these waves represent depolarization of the ventricles. Note that the total duration of the QRS complex is similar to that of the P wave. This is, in fact, surprising since the ventricles are so much larger than the atria. However, the ventricles depolarize just as quickly as the atria because conduction velocity through the His-Purkinje system is much faster than the atrial conducting system. The T wave represents repolarization of the ventricles. Going back to atrial repolarization, remember that this cannot be seen because it is buried within the QRS complex. The QT interval includes the QRS complex, the ST segment, and the T wave, and represents the first ventricular depolarization to last ventricular repolarization. The ST segment is an isoelectric portion of the QT interval that correlates with the plateau phase of the ventricular action potential. Alright, so that was it for EKG basics. I hope you liked the video. If you did,
I don't quite understand the weird pauses. Okay, so we took a look at that. Now we'll move on to diseases of the electrical system. So first we'll take a look at bradycardia. So anytime you see the word Brady in the medical field, it has to do with something that is slower or lower than normal. So bradypnea would be slow breathing. Bradycardia is a slow heart rate. It is caused by a slow rate in the SA node or a possible block in the electrical conduction pathway. So causes coming from the SA node could be sleep. Generally, we have a lower heart rate when we sleep, which is pretty normal. Ischemia, so low blood flow or oxygen supply to the atria could cause us to not have enough blood flow to the SA node. Medications can lower our heart rate. And then increased vagal tone. So this refers to the vagus nerve. Have you guys learned about the vagus nerve in health assessment? We love her. Some of you have, some of you have not. You're all in the same health assessment class. That makes me nervous. Has everyone heard of like your fight or flight response? So that has to do with your sympathetic nervous system. So when your sympathetic nervous system is active, you have a fight or flight response. If your parasympathetic nervous system is active, you have a rest and digest response. Okay, so parasympathetic nervous system is more active when you're sleeping. Sympathetic nervous system is more active, like if I were to call on you in class and ask you to answer a question. You wouldn't like that very much. Anyway, the vagus nerve is part of our parasympathetic nervous system. So an increased vagal tone leads to a slowing down of the systems controlled by the vagus nerve. And how do we increase vagal tone? So here's an example. Someone comes into the emergency room, they have a super high heart rate that the medical team decides needs to be lowered in some way. In order to do that quickly, especially before you have IV access or you're able to do that using like a defibrillator or something, you might ask them to bear down like they're trying to have a bowel movement. So you ask them to bear down, that increases vagal tone, which will slow the heart rate. So increased vagal tone can slow the heart rate. It can also make you pass out because your heart rate starts going too low. So there's sometimes, if you've worked with the elderly, sometimes they'll pass out on the toilet. It's not great, especially if you work in a place where you count falls, because there's another one. All right. So it can also be caused by abnormal conduction. So there can be all sorts of reasons that you could have abnormal conduction, and we're going to go into those. You could have abnormal conduction through the AV node, a particularly slow AV node, PR segment. And then you could have ectopic pacemakers, which we will also go into, where the SA node isn't firing the way that it should. And so the ectopic pacemakers in other areas of the heart begin to fire, and they have slower rates. So, and we will get into that. There are also 4 types of what's called heart block: 1st degree, 2 types of 2nd degree, and a 3rd degree. But however, bradycardia can be a normal finding in athletes because their hearts are a bit more efficient than the rest of us. All right, let me make sure I went over all my notes. I did. Okay. So, going into these intrinsic pacemakers. So every cardiac cell has an intrinsic pacemaker, a built-in pacemaker. If the SA node, what normally fires the first beat, if the SA node fails to produce an electrical impulse at a rate faster than the cells further along the conduction pathway, the cells in the AV node or Purkinje fibers will fire on their own. The further down the conduction pathway you go, the slower the rate. So if the AV node is the first to fire, the rate will be around 40 to 60 beats per minute. And if the Purkinje fibers are first to fire, the rate will be around 40 beats per minute. Due to slower conduction in the ventricles, action potentials that originate in the ventricles, so the Purkinje fibers closer to the AV node, will lead to a wider QRS complex on EKG. Let me just look at my notes. So reasons the SA node may fail include age-related degeneration, heart damage, inflammation, medications, infiltrative diseases, and electrolyte imbalances, which we will learn more about in the renal portion of this course. And then the wider QRS complex that we talked about is due to it taking a longer amount of time to depolarize the ventricles, which is the action being shown by the QRS complex. Bless you. All right, types of heart block. So, again, there are 4 types of heart block: 1st degree, 2 types of 2nd degree, and a 3rd degree. For this slide, you do not need to be able to recognize these strips. Recognizing heart block is a little bit more complicated than your 3rd week of nursing school, okay? However, you should be familiar with the explanation, okay? So if I ask you an exam question on the explanation, you should be able to understand which type of heart block I'm talking about. But you do not need to be able to look at a strip and recognize heart block, okay? So 1st degree heart block, the impulse is delayed when reaching the AV node, so you have a lengthened PR interval on EKG. So this is just only simply a long PR interval. A longer than normal PR interval is 1st degree heart block. And it's because we're having a delayed impulse when it reaches the AV node, more delayed than normal. Okay, so there are 2 types of 2nd degree heart block. The first type 1, is called Winky Bach. It's a weird name. There's got to be a German person behind it. A Winky Bach is a progressive lengthening of the PR interval before a dropped beat. And if you look over at this little image, you can see there's a rhyme that goes with this. If the R is far from P, then you have a 1st degree. Longer, longer, longer drop, then you have a Winky Bach. So you have a PR interval that goes from normal or closer to normal, and it gets longer progressively until there is a dropped QRS complex. In type 2, impulses do not travel to the ventricle in a regular pattern, leading to dropped beats. So in the rhyme, if some P's don't get through, then you have a Mobitz 2. So if some P's don't have a QRS complex associated with them, you might have a second degree type 2 heart block. But the difference is that you don't have that progressive lengthening of the PR interval. So first degree, you have that progressive lengthening of the PR interval. Second degree, you do not. Second degree type 1, second degree type 2. Third degree is known as complete heart block, and that is when there's no conduction at all between the atria and the ventricles. So they are each beating to their own intrinsic pacemaker rate. So the atria are beating somewhere between 60 and 100 beats per minute, and the ventricles are beating between 40 and 60 beats per minute. And so your EKG is going to be all over the place because they're just not communicating with each other at all. All right, you do not need to know any treatments at all, mechanical, medical, medicinal, or otherwise, for the exam. However, this information is for you as a first pass because you may need to know those in subsequent classes and on the NCLEX. So, the treatment for bradycardia or heart block is to increase the heart rate. So you would use beta agonists. You may also need a pacemaker, which is shown here. It's this little implanted device. The wires are threaded into the heart, and they are able to control the rate of contraction in your heart. You also want to decrease inhibition. So you want to decrease that vagal tone and that parasympathetic response. You would use anticholinergics like atropine, and you may also, again, use a pacemaker. All right, now that's bradycardia, and we will move on to tachycardia. So tachyarrhythmias, or arrhythmia meaning any abnormal heart rhythm, tachyarrhythmias meaning fast heart rhythms. So tachyarrhythmias are classified by where they occur. If they are above the ventricles, they are considered supraventricular, and if they are in the ventricles, they are considered ventricular. Okay? Supra meaning above, ventricular is pretty obvious. And then tachy, anytime you see the word tachy in medical terminology, it means fast or higher than normal. All right, so you can have sinus tachycardia. Sinus tachycardia means you have a normal heart rhythm, that's the sinus, a normal heart rhythm, but a fast heart rate. So your heart is beating over 100 beats per minute, but the rhythm is normal. Your P waves look normal, your QRS is normal, your T wave is normal, everything's normal, it's just fast. So, the SA node is firing at over 100 beats per minute due to a sympathetic nervous response to a physiologic state. It can be due to a sympathetic response to a physiologic state, such as exercise or fear, or a pathophysiologic condition, such as fever, dehydration, or pulmonary embolism. Some of these things, so especially dehydration and pulmonary embolism, the reason for the tachycardia is that your heart is trying to increase cardiac output. It has sensed that your blood volume is low, or it is having trouble perfusing all of your tissues, and so it's trying to increase cardiac output. And it's doing that by increasing the heart rate. It could also be due to a combination of the two, as in a combination of a physiologic state and a pathophysiologic condition, such as a response to pain or panic. There's also a condition called POTS, so it's inappropriate or postural sinus tachycardia, and that's, for people with POTS, it's a whole large spectrum of a disease. Everyone suffers from it differently. But someone might be sitting in this classroom and their heart rate is normal, and as soon as they stand up, their heart rate skyrockets. So for those of us who have a normal heart rate and a normal heart rhythm, our heartbeat might go up 20 to 30 beats when we stand up. Theirs might go up 100. Like it just is inappropriate, and it's posturally related. And there are lots of things you can do to treat that, but it is not something that is considered curable. All right. So these are two big heart rhythms that you will need to know, especially on the exam. Atrial flutter and atrial fibrillation. These are supraventricular, meaning they take place above the ventricles, which hopefully you could tell because they're both atrial heart rhythms. So both are considered what's called a re-entrant circuit. Electrical impulses travel around the atria in a circle instead of moving down the typical electrical pathway of the heart, causing variations in P waves. In atrial flutter, you have loops around the atria at a high rate of speed, leading to a sawtooth appearance on EKG. So in atrial flutter, let's see, I think I have a marker somewhere if they don't have one. They don't want to share any markers with us, apparently. It's fine. It's orange. Hopefully this works.
I have a black one. Do you want a black one?
I think you guys will be able to see the orange one. I don't know how to make this thing go away though. I don't want to shut everything down. Although apparently I already turned it off somehow. Okay, well, I'll draw it over here and then maybe I'll draw it on the other side. Okay. Here's a heart. Okay, I'm not an artist, but that's a heart. So, in atrial flutter, you have a re-entrant circuit, but you just have one. And it's just firing over and over and over again instead of traveling down like it normally would, okay? So you just have this re-entrant circuit up in the atria, and eventually the impulses get through. In atrial fibrillation, you have multiple re-entrant circuits, and they're just firing completely randomly, and it's completely irregular. Are you guys able to see that on that end? Okay, then I won't draw it again, because my art skills leave much to be desired. All right, so atrial flutter loops around the atria at a high rate of speed. Because it's regular and it's just that one big re-entrant circuit, you're going to have what's called a sawtooth appearance on EKG, which we will see on the next slide. There can be up to 400 atrial beats per minute. In atrial fibrillation, also known as AFib, multiple circuits of re-entry in the atria, like I showed you, leading to a higher degree of irregularity. This can be over 400 atrial beats per minute, and the ventricles will often beat 100 to 150 beats per minute due to the refractory period in the AV node. So they still need to have that refractory period before they can depolarize again. So the ventricles can only keep up at a rate of about 100 to 150 beats per minute. Let me see. Let me make sure I give you all my notes. Okay, I'll read this part. The regularity of the sawtooth pattern in atrial flutter is one way to distinguish between atrial flutter and atrial fibrillation. The P waves in atrial fibrillation will look completely random and irregular, or they won't show up at all because they're just happening one after the other. All right, so you can see that here. The top strip is atrial fibrillation and the bottom strip is atrial flutter. There are EKG strips on the exam where you have to say, this is what I'm looking at. Okay? Yes?
Could you say that part again about distinguishing between the flutter and
Sure.
the
The regularity of the sawtooth pattern in atrial flutter, is one way to distinguish between atrial flutter and atrial fibrillation. The P waves of atrial fibrillation will look completely random and irregular, or they won't show up at all. And you can see that here. So in atrial fibrillation, the P waves are completely random. They don't occur in any specific order. They're just there. And the ventricles are doing their best. But like I was saying, you do need to be able to identify these two EKG strips if you're looking at the exam, on the exam, I should say. And then you can see that, sorry, this thing is right next to my knee. All right, you can see that atrial flutter has this very like symmetrical, almost sawtooth pattern where every beat looks fairly the same, and that's because of that re-entrant circuit that is not as irregular. So causes of atrial flutter and atrial fibrillation include heart disease, such as myocardial infarction, which again is a heart attack. Infarction meaning tissue death, so a heart attack. Heart failure and valvular diseases. This can also be caused by pulmonary diseases like COPD or a pulmonary embolism, mostly because you can end up with right-sided heart failure. And then hyperthyroidism. So if you have hyperthyroidism, your metabolism is moving a lot faster, which causes your heart to beat faster. And hypertension, because hypertension can lead to left-sided heart failure. All right, so complications of atrial fibrillation. AFib causes the atria to quiver instead of contract, leading to inadequate movement of blood through the heart. This leads to turbulent blood flow within the atria. In the left atria, if a clot forms due to this turbulence and the propensity of blood to spend a longer amount of time in the atria, the clot can eventually pass into the left ventricle and out into systemic circulation. So you're up in the left atria and they're just quivering, okay? They're not squeezing blood into the ventricle like you want them to. That blood that's just sloshing around in the atria instead of moving forward like it's supposed to can begin to clot. Once a clot enters systemic circulation, it can cause major damage, leading to stroke, mesenteric ischemia, and renal ischemia. So stroke, because it can go through the carotid arteries up to the brain. Mesenteric ischemia is ischemia to the bowel, which will lead to severe abdominal pain, and renal ischemia to the kidneys. Anticoagulation, as in blood thinning medications, will often be necessary for people who have atrial fibrillation. This, I think, is a picture of a blood clot in the atria that is very scary. So you can see on echocardiogram, it looks like there might actually even be 2 blood clots in there, and you're just begging them to not pass into the ventricles. All right. Okay, so now we're going to move on to ventricular tachyarrhythmias. So now we've moved from the atria down to the ventricles. Ventricular tachyarrhythmias, abnormal depolarization of the ventricles. Ventricular tachyarrhythmias often result in a widened QRS complex on ECG. And the reason for that is because the ectopic impulses, so impulses that occur outside of the regular conduction pathway, ectopic, cause the rhythms to spread partially or entirely outside the ventricular conduction system. And that's what leads to a slower depolarization. Ventricular tachyarrhythmias, we just talked about that. A normal QRS should be less than 0.12 seconds. And then uncoordinated muscle activity can lead to a sudden decrease in forward flow, which is often a medical emergency. So you can see one of these here. This is VTAC, ventricular tachycardia, but it's often just referred to as VTAC. This can result from a re-entrant circuit in the ventricles or from ventricular cells firing at an increased rate. It can be a result of myocardial infarction, so that tissue death can cause issues with the nerves and pacemaker cells. Dead tissue leads to abnormal electrical conduction properties. So on VTAC, you see almost a tombstone pattern. It's just large, long, skinny waves, and those are all QRS waves. And because they're occurring so close together and they're so wide, you can't see any other waves on the EKG. All right. Next, we have ventricular fibrillation. So ventricular fibrillation, or VFib, is the result of multiple reentry circuits in the ventricles. So we talked about AFib, and now we have VFib. It is more uncoordinated than ventricular tachycardia, and therefore it is more severe. cardiac output is more impaired than in ventricular fibrillation than in ventricular tachycardia. It can be a result of tissue death from myocardial infarction or as a direct result of a progression from ventricular tachycardia. So you can go from having ventricular tachycardia to having ventricular fibrillation. It will result in sudden death without prompt medical intervention. So ventricular fibrillation, your ventricles are basically quivering instead of pumping blood out into systemic circulation. You're not perfusing your brain adequately, so it will lead to sudden death. The way that you fix that is by shocking the heart back into a regular rhythm. You must shock someone who's in ventricular fibrillation back into a regular rhythm, or they will die. That said, there are a couple of, you can shock someone in AFib, you can shock someone in VTAC, you can try and get them into regular rhythms using electrical energy from another source, but there are two rhythms that you cannot shock because you cannot create electrical energy out of nothing. So those two rhythms are asystole, which is an absence of electrical activity. It's when you see on like medical shows a flat line, that's asystole, A-S-Y-S-T-O-L-E. And the other is pulseless electrical activity. So those are the two heart rhythms you cannot shock because there is no electrical activity involved. For people who are in asystole or PEA, pulseless electrical activity, you can give them medications like epinephrine in hopes of restarting their heart. And that's where CPR comes in, right? You need those medications to flow through the bloodstream, and the only way to do that is through CPR. Yes?
Is epinephrine adrenaline?
Yes, same thing. All right. So, as we look at tachyarrhythmias, so treatments include medications to decrease the rate of firing, cardioversion, which is what we were talking about a little bit, that electrical reboot of the heart. This is particularly important in people with hemodynamic instability. So hemodynamic meaning your blood flow. So if you have an unstable amount of blood in your body, this is the safest option for you. So this could be people with low blood pressure, caused by a number of things, right? So you could have low blood pressure just because you have low blood pressure, or you could have low blood pressure because you have a wound of some sort that's hemorrhaging. You could have low blood pressure after childbirth. There's a number of reasons, but if you are hemodynamically unstable, then usually delivering electrical energy to the heart is going to be the first resort. And then there's also ablation. So ablation is what you see in this image. They can go up through the femoral artery using these catheters, and the ends of the catheters are used to burn the areas of dead tissue and the nerves that are causing these abnormal rhythms. And they can use ablation in the atria or the ventricles. All right, now we have diseases of the cardiac vasculature. This class ends at 1:55. Okay. Yes.
The two-part patterns that you can't shock.
Yes. Asystole, A-S-Y-S-T-O-L-E, and pulseless electrical activity. Yeah. All right. So, moving into diseases of the cardiac vasculature. So we have to remember that the coronary arteries supply blood to the heart. So you can see it in the image here. The coronary arteries are these vessels surrounding the heart that perfuse the heart itself. They perfuse the heart. If you remember, when do they perfuse the heart? During diastole. During filling, okay? They cannot perfuse the heart during ventricular contraction. They can only perfuse the heart during diastole. So, damage to the vasculature can lead to a lack of oxygen, poor perfusion of cardiac tissue, tissue damage, and insufficient cardiac function. The way that this happens is through something called atherosclerotic plaques. So that's the word you can see here. Atherosclerotic plaques are formations of lipids and cholesterol in the vessel lumen. There's a picture of it on the next slide. And it builds up. And these plaques build up and build up and build up and begin to occlude the vessel, limiting blood flow through the vessel. So these atherosclerotic plaques tend to have a little bit of a hard capsule on the top of them. If the plaque continues to grow and that capsule ruptures, the body's own responses will draw clotting factors to the area and a blood clot will begin to form. That blood clot can even further occlude the vessel, leading to a complete ischemia or complete lack of blood flow. Risk factors for the development of atherosclerotic plaques in the coronary arteries include diabetes, smoking, high blood pressure, and high cholesterol. Atherosclerotic plaques can lead to blood clot formation, cutting off blood flow and leading to angina and or myocardial infarction. Angina being chest pain related to ischemia. All right, so you can see here, atherosclerosis, so you see that plaque forming, and then it continues to form before it has a growth and rupture. And that rupture is where those blood clots start to form. This can be treated with a stent in some people. I don't honestly know the amount of people that can be treated with a stent and those that can't. But a guide wire is entered, this balloon is inflated in order to open the vessel lumen, and then this mesh is left in place so that blood can flow freely through the vessel. All right, so we talked about this a little bit last week, but we'll talk about it again. Angina. So atherosclerotic plaques narrow the vasculature and prevent vasodilation of the coronary arteries. This prevents adequate perfusion and leads to a chest pain and tightness known as angina. This typically starts with exertion and is known as stable angina. So you're walking up the stairs with your groceries and you're like, oh, my chest hurts. You put your groceries away, you sit down, and the chest pain goes away. That's stable angina. If angina begins to be felt at rest, it becomes known as unstable angina. So now we're having blood flow issues at rest, not just when you're exercising or with activity. Unstable angina is one of the presentations of acute coronary syndrome, which we are about to go over. Okay, so acute coronary syndrome. Once a thrombus or clot begins to form, occlusions of the vessel can occur, leading to ischemia, lack of blood flow, and preventing perfusion of that area of the heart. So you think about it, you have a clot, now the entire vessel distal to the clot, distal meaning past on the far end of the clot, there's no blood flow there. So any areas distal to that clot are not being perfused. The opposite of distal is proximal, proximal meaning closer. So this is known as acute coronary syndrome and can result in 3 presentations. The first of which is unstable angina that we just talked about, that chest pain related to ischemia that now is happening at rest in addition to with exertion. You can have a non-ST wave elevated myocardial infarction, which is known as an NSTEMI. If you're in the hospital and someone talks about an NSTEMI or a STEMI, this is what they're talking about, a non-ST elevated myocardial infarction. Or you can have the STEMI, which is an ST elevated myocardial infarction. All right. So now you can see on those strips at the top of this image what that kind of looks like. So you see the normal ECG first, you see a STEMI, so you see that elevation of the ST segment, and then an NSTEMI, so a non-elevated ST segment. It doesn't always look quite as severe as you see in these pictures. Sometimes it's a little more normal looking than this. But regardless, that's a STEMI and that is an NSTEMI. They're both forms of myocardial infarction, so these are both forms of heart attack. Infarction means that there is tissue death associated with the ischemia. Angina involves no infarction, only ischemia. So there's no tissue death if you only have angina. Okay, Signs and symptoms of myocardial infarction: acute chest pressure, which can radiate into your arm, jaw, or neck; dyspnea, which is a difficulty breathing or shortness of breath; nausea and vomiting; and sweating. Non-traditional presentations may be seen in people with diabetes, 2X chromosomes, or those born female, assigned female at birth, the elderly, and those who have had a heart transplant. The reason that people with diabetes and the elderly may not have traditional presentations of myocardial infarction is because of something called neuropathy. And neuropathy is basically a degeneration of the nerves. And that can just happen with normal aging, but it is also a consequence of diabetes. So I don't know, some of you have worked in the medical field, probably most of you. Has anyone ever seen like what's called a diabetic foot? Yeah, so these diabetic feet, one of the first places you lose that nerve function with diabetes is in your feet. And so you don't always notice if you have an injury to your foot. And then you do get this injury to your foot, and it's very slow healing. And it can lead to, again, kind of an ischemia situation where there's not enough blood flow to the area. It can lead to infection, and a lot of people with severe uncontrolled diabetes end up with having toes removed, feet removed, things like that. Their feet can turn black. It's pretty awful. People assigned female at birth traditionally have had been underdiagnosed with myocardial infarction. And that's because their symptoms aren't always the same as you would have seen in people not assigned female at birth. So prior to about 40 years ago, there really wasn't a lot of research done on female patients. So all the medical research that was done on white male patients. And then things started to change, and we started doing research on other people, and we realized those were important things. So, however, that has left any other population at somewhat of a disadvantage when it comes to these things. And so people assigned female at birth might present to the emergency room with different signs and symptoms as those who weren't, one of which was like this feeling of doom or this anxiousness, knowing something is wrong, but you can't describe what it is. And so then these people were told that they had anxiety and they were having panic attacks and things like that, when in reality they were having heart attacks. And then the last one is heart transplant. In heart transplants, they don't always hook up the nerves that control chest pain, so they may not know that they have this ischemia going on. Then there is always a possibility of a silent infarction where patients experience no symptoms at all, and that is not great. Okay, we've got a little bit longer before our friends can present. Next, we'll look at diseases of the cardiac vasculature. Oh, we're already looking at diseases of the cardiac vasculature. I lied. So, looking at STEMI and NSTEMI, they are differentiated entirely by ECG findings. So, whether or not there is an ST elevation is what makes something NSTEMI or an NSTEMI. STEMI and NSTEMI are differentiated from angina by laboratory testing and echocardiogram. So, if you are having a myocardial infarction, so that death of tissue, you will have elevated creatine kinase and troponin levels. These are substances released by the cardiac muscle when cardiac tissue begins to die. So these substances then will build up in the blood, and you'll see higher levels of them on blood tests. So anytime someone goes to the hospital with chest pain, they are most often going to receive these lab tests so that we can tell. They also do like serial troponin levels, so they'll draw one and they'll say, okay, this is your level, and then they'll check it 2 to 3 hours later and see if it increased. Myocardial infarction may show up as wall motion abnormalities on echocardiogram. So say that I have a myocardial infarction and I'm having death of tissue in my left ventricle. My left ventricle is not going to beat and contract as effectively And so that might show up on an echocardiogram as something abnormal with my heartbeat, with the contraction, I should say. All right, again, you don't need to know treatments, but these are here for your knowledge. Treatment of angina includes dietary and lifestyle modifications, reduced fat intake, smoking cessation, weight loss, cholesterol-lowering medications, antiplatelet medications, because we want to decrease the number of clots that can form, decrease the oxygen needs of the heart, and then increased vasodilation. If you really love learning about medications and pharmacology, you have a whole beautiful image here for you. All right. Treatment of acute coronary syndrome medications include antithrombotics. So these would be antiplatelet medications, anticoagulants, thrombin inhibitors. These are things that cause blood clots, so we want to do the opposite. Vasodilators, so that we can increase the size of the lumen and increase blood flow. Beta blockers to slow the heart rate, and statins to lower cholesterol. We learned about the percutaneous coronary intervention, which is that balloon angioplasty or stent. But you can also have a coronary artery bypass, graft. This is not something that you can do through a vessel where you can go in through the femoral artery. This does have to be done through your chest, through an incision. But basically, they take a vessel from your own body and they attach it to your aorta. So you can see it up there attached to the aorta, and then they attach it distal to the blockage, so past the blockage, to perfuse the area below the blocked vessel. And that is what a bypass is. And you can have multiple, as you see here, you can have multiple bypasses, which the more you have, the more infarctions you have, which is unfortunate. All right, complications of myocardial infarction include arrhythmias, ischemic cardiomyopathy, so damage to the left anterior descending artery, which perfuses the left ventricle, can lead to left-sided heart failure if the muscle of the left ventricle becomes damaged. We can have papillary muscle rupture, which we talked about last week. It's the #1 cause of acute mitral regurgitation. And you can also have ventricular wall rupture. So when you're looking at the heart, the ventricles each have two walls. They have the septal wall, which is the wall between the two ventricles, and they have the free wall. The free wall is in contact with the pericardial sac, the sac that surrounds the heart. So a septal rupture will lead to a ventricular septal defect and a systolic murmur, a murmur during squeezing. And a free wall rupture will cause blood to leak out of the heart and into the pericardial sac, leading to what's called cardiac tamponade. And cardiac tamponade is when the heart is drowning in its own blood. So the blood is stuck in the pericardial sac and it's drowning the heart. So now the heart is unable to beat effectively. It is a huge medical emergency. All right. I'm going to stop there as far as new material goes. Let's get some cards out. And in like 5 to 10 minutes, we'll do our little presentation. All right. I would know what ions flow into the cell at what time. So prior to reaching threshold, there's a slow influx of blank ions into the cell. prior to reaching threshold, there's a slow influx of blank ions into the cell, and on the back, Na plus or sodium, that's up to you what you write, whatever will help you remember it.
Can you repeat that?
Yeah. Prior to reaching threshold, there's a slow influx of blank ions into the cell. Prior to reaching threshold, there's a slow influx of blank ions into the cell. And the back would be Na plus or sodium. They're the same thing, but written different. Did you guys have to take chemistry to get into this program? Okay, so you know what you're looking at. Thank God. Because there's some lectures you guys are going to get to watch that are very chemistry based. Enjoy. Anyway, okay. Perfect. So I would know your resting membrane potential and your threshold membrane potential. So on one side, resting membrane potential. On the other side, negative 60 millivolts. On the next card, threshold membrane potential. And on the other side, negative 40 millivolts. So resting membrane potential, flip it over, negative 60 millivolts. Next card, threshold membrane potential, flip it over, negative 40 millivolts. All right. Make sure you know what you're looking at if you're looking at a normal EKG. So, the P wave represents blank. Atrial depolarization is the answer. The P wave represents blank, and atrial depolarization is your answer. The QRS complex represents blank, and ventricular depolarization is the answer. QRS complex represents blank, ventricular depolarization is the answer, and the T wave represents blank, and repolarization is the answer. You can also put the PR segment and ST segment on there, but I'm going to move on for the sake of time. I would put, like, for this one I would say blank is a heartbeat less than 60 beats per minute, and on the back you could put bradycardia. Blank is a heartbeat less than 60 beats per minute, and you can put bradycardia on the back. And conversely, you can do the opposite, right? Blank is a heartbeat over 100 beats per minute, and put tachycardia on the back. So blank is a heartbeat over 100 beats per minute, and you can put tachycardia on the back.
Do we have to know the difference between ventricular escape beat and junctional escape beat?
No. No, you do not. You do need to know the differences between all four of these types of heart block. You do not need to be able to read the EKG strips for heart block.
Sorry, can you say that again?
I said you don't need to know the EKG strips for heart block, but you do need to know the differences between the four different types of heart block. So you need to know that secondary type 1 is a progressive lengthening, secondary type 2 leads to dropped beats, but there is no progressive lengthening. Third degree, no conduction at all. You need to know those parts of this information. You need to be aware of the appearance of these two rhythms. So the appearance of atrial fibrillation and atrial flutter. You will have EKG strips on your exam that you have to look at and tell me what rhythm you're looking at. I'm skipping things, but you guys can go back and make cards as well. We just only have about 3 minutes until we need to have the group that's presenting start getting their stuff ready. Make sure you know your rhythms that can't be shocked. And make sure you know your rhythm that must be shocked, which is this one, ventricular fibrillation. Which rhythm must be shocked, which rhythm is in a medical emergency and must be shocked. However you want to write that is up to you. And the answer is ventricular fibrillation. But also put on the same card or another card which rhythm will lead to sudden cardiac death without prompt medical intervention. That's that last bullet point on here. Which rhythm will result in sudden cardiac death without prompt medical information or intervention? And the answer is ventricular fibrillation. You should know the 3 presentations of acute coronary syndrome. So on one side, you could put 3 presentations of acute coronary syndrome. And on the other side, you can put these 3 bullet points: unstable angina, NSTEMI, and STEMI. You don't always need to write out the full name of those. Everyone will know what you're talking about if you just use the abbreviations. All right, probably have time for one more. Actually, I'll just leave that up there. We'll make that the last one. And I'll just leave it up there for you. Whoever's presenting today, if you would email me your presentation, I will pull it up on my SU email. That's usually the fastest way to get it up. Does anyone still need this slide? Okay. All right, we can take a 5-minute break, and we will come back